Hi, welcome to today's webinar from Virta Health. Data-driven is just the beginning why the details of evidence matter. My name is Jim McCarter. I'm the head of research at Virta Health. So what we wanted to kind of talk with you about today is to understand our perspective on evidence at Virta Health and why, as you look at healthcare solutions for your organization, the details of that evidence matter a great deal. Here's the kind of outline for today's webinar. I'll talk about how there is really an ocean of products out there, oftentimes with only a drop of evidence. I'll talk about what are different types of clinical evidence and how they form somewhat of a hierarchy in terms of how clinicians and research scientists think about them. And then we'll go into detail around three particular questions that you should be asking those who bring healthcare solutions to you. One, are you measuring what matters? Two, have you conducted a clinical trial? Three, have you published your results? I think those are all key questions to be asking those who propose different healthcare solutions. And then we'll do some concluding thoughts and questions and answers. So let's go ahead and get started. So first, there really are an ocean of products out there, and oftentimes, unfortunately, only a drop of evidence. So just as a thought, how many apps do you think there are in mHealth? And I was really surprised by this number, but a 2017 research report indicated that there actually are 318,000 mobile apps that are available from the App Store and other online sources. But how many studies then actually support the evidence that these apps are effective at improving someone's health? Well, that same report found 571 published studies indicating that the app had some kind of an efficacious effect on someone's health. And then looking particularly at weight loss apps, there actually, as of a 2016 review, found only 65 publications that showed efficacy of those apps or tested the efficacy of those apps for weight loss. So oftentimes, a huge number of product offerings with only a small amount of published evidence to indicate that they do what they say. Now, the wellness industry, the workplace wellness industry, has a reputation for under-delivering on its promises. Oftentimes, there are few clinical trials, there are few publications, and overly optimistic return on investment claims. And here are some examples of sources for that, both a published study, as well as just for fun, several podcasts that I've found illuminating in terms of kind of looking at the problem with these overly promising claims that then underdeliver when you actually look at the data of the wellness industry. Even traditional medicine is full of unproven interventions and recommendations. In the 1980s, there was a whole movement around evidence-based medicine, but we really have still a long way to go in terms of undoing the mistakes of the past. There's an excellent book that I'd suggest people read called Ending Medical Reversal, Improving Outcomes and Saving Lives. It has a number of these examples of cases where we had an intervention in medicine that we thought was efficacious, but on closer examination with better data, it turned out that it actually either had no benefit or even in some cases was harmful. And then within nutrition, we've seen this again and again, where there were recommendations based on shaky evidence that then have since been overturned, and that includes recommendations around reductions in dietary cholesterol, the idea that trans fats were safe to consume, and now we're in the middle of rethinking this whole topic of low-fat diets and whether or not those were a good idea. So let's talk a little bit about medical evidence and clinical evidence. Going back again to evidence-based medicine, as this began as a field in the 1980s, clinicians have come up with a number of rubrics or hierarchies of thinking about kind of how to organize different levels of evidence. And so here's one from the Oxford Center for Evidence-Based Medicine that has sort of a gradation from 1 at the top down to 5 at the bottom in terms of thinking about levels of evidence. Here's another one from the American Diabetes Association that's grading evidence A, B, C, D, and E. You can also look at these as sort of a pyramid hierarchy of weighting of different evidence. Here's another version of the Oxford EBM levels of evidence pyramid. And so the things that are kind of down at the bottom would be anything that's unpublished. So for instance, anecdote or customer testimonial, marketing materials, those wouldn't even really be considered in evidence-based medicine because they're unpublished. And then in terms of foundational medical literature around animal models and laboratory-based evidence, those would be down at the bottom as lower levels of evidence. They're really sort of setting the rationale and questions that need to be asked then with these higher levels of evidence, which are non-randomized clinical trials, randomized clinical trials, and then aggregations of those clinical trials into systematic reviews and meta-analyses that are considered higher levels of proof. So keep those in mind as we think about these different types of evidence that we'll be seeing over the course of the webinar. So to begin, I'll talk a little bit about the evidence for the Virta intervention. So Virta Health provides a clinic nationwide via telemedicine for the reversal of type 2 diabetes. And the intervention that we bring to our patients has a large nutritional component. And that nutritional component is based on decades of research. And that was actually 3 years ago when I joined the company. One of the attractions to me of Virta was that our founders had been doing clinical trials for several decades looking into this nutritional intervention. There are now 8 meta-analyses and systematic reviews, as well as 27 randomized controlled trials on thousands of patients that support aspects of the efficacy and safety of Virta's nutritional recommendations. So most of that data predates the establishment of the company 4 years ago. And then what we've been doing since is to begin to say, okay, we have a series of nutritional recommendations that we think are favorable in terms of reversing diabetes. Can we actually deliver that with our own care model in a way that's efficacious? And so we've undertaken, and this began 3 years ago, a clinical trial in partnership with Indiana University Health to support the efficacy, safety, and sustainability of combining those nutritional recommendations with Virta's continuous remote care model of telemedicine. And I'll be talking a little bit about data from that trial today. We've also then more recently, as we've commercialized the Virta intervention, we've established the Virta Health Registry for the Remote Care of Chronic Conditions. And this enables all of our commercial patients to consent for the use of their data, aggregated and anonymized data, for medical research and for publication. And so what we're trying to do there is to demonstrate that our commercial outcomes can be compared to our published research findings, and to look at not just hundreds of people, but to look at many thousands of people over time that are receiving care from Virta Health. So I'll be talking about the clinical trial from Indiana a number of times, and so I thought I'd give you just a little bit of background about this. As I mentioned, this began in the summer of 2015, and we began a 5-year non-randomized prospective controlled trial with nearly 500 patients, 262 with type 2 diabetes that I'll talk about today, another 116 with prediabetes that received the Virta intervention, and then another 87 individuals independently recruited as a usual care or control arm within the trial. We did a non-randomized trial design to allow patient choice and to avoid some of the confounders that can come with the recruitment and behavior of patients in a randomized controlled trial. So let's talk about these 3 questions then. And I'll be using examples from Virta's data as well as some examples from other vendors that provide health offerings to enterprise customers. So let's start with this. Are you measuring what matters? And are you measuring what matters, not just in general, but are you measuring what matters to health? So there's something called the streetlight effect that occurs when people search for their car keys or whatever it might be, where it's easiest to look under the light. And I think a good example of this really is this whole adoption of pedometers and accelerometers in wellness, in corporate wellness initiatives, with very little evidence that these are actually useful as a health metric. You know, it's fun to measure your steps and see if you've got 10,000 steps per day, but there's actually, in terms of the published literature, little to indicate that you're actually going to see a health benefit from that pedometer outcome or in particularly a weight loss benefit from the supposed greater level of exercise that's going to occur if people are given a pedometer. So what we've decided to do with Virta is to really concentrate on these metrics that matter to health. And a great example is hemoglobin A1C. So we know from decades of use that this is a standard metric for diabetes diagnosis. So for the individuals that we're treating that have type 2 diabetes, hemoglobin A1C is tracking the level of glucose in the blood over time. And a level of 6.5% or greater is considered the diagnostic threshold for type 2 diabetes. And then because A1C isn't perfect, it actually depends upon the lifespan of the red blood cell. And so it's not always 100% accurate. We've actually reported from our clinical trial another half dozen metrics to make a comment about people's type 2 diabetes status that correlate well with the outcome that we see from their hemoglobin A1C. So we're measuring a metric that matters. And here's some examples then from the clinical trial. We showed a reduction in people's mean hemoglobin A1C for the 262 people with type 2 diabetes in the trial, doing both an intent to treat analysis, where you look at kind of all comers who begin the trial, as well as a completers analysis, where we look at the 83% of individuals who completed 1 year of the trial. And we show with high statistical significance of greater than or less than 10 to the 16th p-value, that reduction in A1C from 7.5 to 6.2 is statistically significant. So a full 70% of people with type 2 diabetes were able to get under the threshold of 6.5, considered diagnostic for type 2 diabetes, and 60% were able to do that without diabetes-specific medication. And that's what we use as a definition of diabetes reversal, a sub-diabetic threshold A1C without the use of diabetes-specific medications. And then I think it's important to not just look at the mean and the overall statistics, but if the intervention is really efficacious, you should be able to see an effect on almost all individuals who receive that intervention. And that's what we're showing in this scatter plot here. On the left-hand side are the individuals receiving the Virta intervention. On the right-hand side are the usual care folks who were receiving standard of care for type 2 diabetes. What you see in the scatter plot is the x-axis represents the starting A1C value. The y-axis is the 1 year A1C value. And if people have no change, they should be on that horizontal, I should say diagonal line. And you see in the Virta intervention that almost all folks are underneath. And actually 85% improved their hemoglobin A1C by at least 0.2%. Whereas for the usual care folks, you see that scatter on either side of that diagonal line. So we're so confident in our ability to improve hemoglobin A1C that in our contracts, we actually put our fees at risk, not just for the overall population, but for every single individual. So we don't see the specified hemoglobin A1C improvements, then there is we don't receive the full fee for that patient. Okay, so that's an example of measuring a metric that matters. Importantly, in distinguishing what Virta does from other diabetes management solutions, where we talk about this idea of diabetes reversal as opposed to the idea of diabetes management, is that we're actually reducing the medications at the same time that we're seeing that improvement in hemoglobin A1C. And so here you're seeing for the 5 major classes of diabetes medications that we're showing a significant reduction in 4 out of those 5. And actually then in commercial populations, we're seeing even better results where all 5 of those diabetes medication classes are being reduced. And so if you look at the trial results on the right-hand side, where we showed a slight increase in the use of the GLP-1 class, we're actually seeing a reduction in the use of GLP-1 in our commercial deployments on the left-hand side. Okay, so let me pause there before I move on to the second and third question, just to welcome anyone else who's joined the webinar in progress. We're going to kind of spend the next 10 to 15 minutes going through the rest of the slides, and then we'll have a little bit of question and answer afterwards. But thank you for joining this webinar from Virta Health. My name is Jim McCarter. I'm the head of research at Virta. And so we'll continue on then. And the second question that we think is important to ask about evidence is, have you conducted a clinical trial? And a clinical trial is really a very different beast from many other ways of gathering information about outcomes. It's conducted by professionals who are trained in human subjects research. It's profoundly different from like a medical records review or other ways of soliciting patient information. It requires approval from either an institutional review board or other types of ethics board. Oftentimes requires consent from the participants. And the registration of the trial is required in order for it to be published. So for instance, is the registration with clinicaltrials.gov of the Virta Indiana University Health trial. And then importantly, the trial usually requires pre-specification of the outcomes that are going to be measured, what's called a prospective as opposed to a retrospective design. So now, knowing a little bit about clinical trials, let's compare that to the claims that you might see from a workplace wellness company, and ask yourself the question as you look at this information, is this real? So here's what this workplace wellness company said, and I just did a screen capture from their website. I won't say who this is, but they said from 2014 to 15 that members with elevated risk factors saw improvements in the following 5 areas. And these numbers look great. Gosh, 82% lower their blood pressure, 63% lower their triglycerides. But be skeptical. There's no trial, there's no publication, there's no controls, there's no thresholds, there's no statistics, and it's what's called a retrospective group analysis. So what they did here is they from the entire population, they picked out the people who started with higher levels and then tried to make a comment about the level of regression of these outcomes. And so let's zoom in on triglycerides, for instance, and I want to compare this to what we've done at Virta. So they made this claim that 63% lowered their triglycerides. We don't know how much, just that those who started with high triglycerides saw them decrease. So here's what we actually published in 2 papers from Virta. This is at 1 year. 75% of our patients completing 1 year showed a reduction in their triglyceride levels. But we know how much. We know that they reduced overall, looking at all starters, a 24% reduction in triglycerides. That's statistically significant at a p-value of less than 10 to the minus 16th. And then we looked not just at triglycerides, which we want to see triglycerides coming down, but why do we want to see triglycerides coming down? Well, because it's a marker of what's called atherogenic dyslipidemia. But that can be measured not just with triglycerides, but with a whole host of factors. So let's actually look at all of those factors. And so what we saw in the Virta trial with a p-value of less than 0.0019 is that all of these factors, triglycerides, the triglyceride HDL ratio, the ApoB, ApoA1 ratio, all these factors were improving. So we have much richer sense of the data. We have statistics to support the data. We have comparison to a usual care group where we show that in general, the markers are not favoring, or not looking so favorable. And so then let's dig in on the Virta data a little bit more and do the same thing that this wellness company did, where they were doing a post hoc subgroup analysis. So they're digging in on the folks that start with a higher level. And so we can do that as well. We can look at the 187 people where we have full data on their triglycerides. And we can look at just the 48%, the 89 people who met the criteria for atherogenic dyslipidemia, which is a high triglyceride, a low HDL at the start, and see how they do. And so the outcome is that 60% of them actually resolve their atherogenic dyslipidemia. So they either see an improvement in their triglycerides or their HDL or both in such a way where they no longer meet the diagnostic criteria for atherogenic dyslipidemia. And so this is a categorical change, not just any small percent improvement, but an actual movement in category. So that looks great. But the thing that you then should ask of this as you interrogate this data is, okay, well, what happened to all comers, not just those who started with a high level? What happened to everyone? And what we see is that the overall picture looks great. So 48% started with atherogenic dyslipidemia. At the end of a year, only 21% meet the diagnostic threshold for atherogenic dyslipidemia. Because what we're seeing is that 53 out of 89 with the condition resolved the condition, and only 3 of 98 who started without the condition qualify for the condition after a year. So it's not as if we see people bouncing back and forth. We generally are seeing people are resolving their atherogenic dyslipidemia. So that's, kind of what a rich data source looks like, and that's how you carefully use a post hoc subgroup analysis. And watch out for particularly noisy data. So for instance, we've done the same type of post hoc analysis with blood pressure, but blood pressure varies so much day to day that you see a lot of movement of people from one category to another. And so the greater the degree of noise in your data, the greater that you'll see people bouncing around. So knowing all of that, then let's come back to this claim from this wellness company and the question of if it's real. So 63% lower their triglycerides. Well, what does that actually mean again? And we don't know how much. 37% of these people who started with a high triglyceride level then therefore must have seen their triglyceride level increase even more. And we don't know anything about those who started with more of a normal triglyceride level. This entire effect of a 63-37 split versus a 50-50 split in people who start with a high triglyceride level could be what's called regression to the mean. And it's this idea that if you do multiple measures, if you see a high value in a highly variable metric on day one, and you measure it again on day 2 or 1 year later, it's likely to be closer to the average upon re-examination. And so watch out for this idea of regression to the mean. That could be the entire phenomenon of which this wellness company is basing their claim. Okay, so that's an example of why you conduct a clinical trial and how prospective data is superior to a retrospective subgroup analysis. Now, another key point is to publish those results. And so I would ask the question of anyone who's bringing healthcare solutions to you, have you published your results? And so peer review, which is the process that biomedical research journals use to review papers to decide whether or not they meet criteria for publication, is a challenging process. It usually takes months. It can often take over a year. It's subject to the biases and blind spots of reviewers. But if you can move through that process and take the time to do it, peer review holds scientists to a higher standard because they expect that the flaws in their methods and the reasoning and writing will be uncovered. So they're taking their research to that higher level standard. So let's take a look at an example. First, I forgot I was going to mention before the example. Virta has 3 peer-reviewed publications to date related to our clinical trial, 1 on the 70-day outcomes, 2 on the 1-year outcomes, and many more in progress, including 1 around non-alcoholic fatty liver disease, 1 that we're preparing around 1-year outcomes for sleep, and then we have 2 papers that we're working on right now that share our 2-year outcomes of our trial. So we look forward to sharing those with you soon. And one of the things actually that's happened recently is that while you're waiting for this, 3 months, 6 months, a year for a peer-reviewed publication to come out, there actually oftentimes is now a way to share that data earlier. Many journals now allow investigators to share their results via a preprint server. The most popular one for the biomedical research scientists is bioRxiv from Cold Spring Harbor Lab. And so we're now, in most cases, submitting our papers there so that they're available as preprints before they're available as peer-reviewed publications. And this has really taken off since it was introduced in late 2013. Now over 1,000 papers a month are being submitted to bioRxiv. So with that as background then, let's look at an example from a population health company that is really an unfortunate example of cherry-picking data. So they state here that 75% of their patients with a BMI of greater than 25 lost between 3.2% and 33.6% of their total body weight. They state that 29% of participants lost an average of 9.5% of their total body weight. So, on first glance, it's like, okay, there's an 33% weight loss. That sounds quite exciting. But what does this really mean? We don't know the average, the mean, the median. We don't know any of the statistics. We don't know what happened to those who are outside of that 75%. What about the other 25%? We don't know about those outside of that 29%. What about the other 71%? So I'll share with you a little bit of the Virta data to show you what higher quality data looks like. And this is based on having people's baseline weight at clinic, 1-year weight at clinic, and then we have, because we provide all of our participants with a cell-enabled scale, We actually have daily weights on most people every single day. And we know that our weight loss, both in terms of an intent to treat analysis as well as a completers analysis that's been published, is 12% weight loss at a year. It's about 30 pounds on average for each of our participants. 86% of our participants who complete 1 year have lost greater than 5% of their body weight, which is considered clinically meaningful. And then what we can do is not just look, again, not like we talked about with the A1C and the scatter plot, don't just look at the means, but let's actually look at all the individuals. And so for everybody who completed a year, here's a histogram of their distribution of weight loss. And so we can share that 86% lost more than 5%, 61% lost more than 10% of their body weight. So that's what high quality data looks like. So with that in mind, then let's go back to this example from this population health company. Fortunately, they published their data in a JMIR publication in 2017. And when you actually go back and look at what was published, their mean weight loss was 3.23%, which sounds a lot less exciting than saying that 75% lost this large range. So the mean is a lot less exciting. And then that 29% lost 9.5%. Where does that coming from? Well, actually, if you go to the publication, what they're doing is they're pulling out just those who lost greater than 5% of their body weight, that clinically meaningful threshold. So if you work the numbers, that means that if you make the assumption of equal distribution of starting weights among those who began their care, that the other 71% of people under their care lost less than 1% of their body weight. So it's a lot less exciting when you actually look at the peer-reviewed data that's held to that higher standard than their marketing claims. Okay, so we've talked about these three kind of key questions of, are you measuring what matters to health? Have you conducted a clinical trial? Have you published your results? And those are three excellent questions among many that you should be asking of those who are bringing healthcare solutions to your attention. And with that, I'd like to thank the research team at Virta for our founders, Drs. Finney and Volek, and then the rest of our research team, Drs. Hallberg, McKinsey, Atharnanyanan, and Bonpuri, as well as Dr. Adams, who recently joined our group. And let's see, so I'll leave this slide up here with further information. Well, I'd like to thank everyone again for taking the time to spend an hour with us talking about the importance of evidence in looking at healthcare solutions. And I should say that these slides will be made available, and also we'll make this talk available on YouTube so that you can refer back to it. Thank you all so much.